Good evening, everybody. Thanks again for the kind introduction to Verma sir. I think our chairperson for this session, Dr. Sati, joined a little late, so I could see he's just joined. So glad to have you with us here, sir. I'm talking about carcinoid syndrome and endocrinology. Now, this is really a topic that is that many people consider to be associated purely with something of concern purely for the oncologist or the gastrointestinal surgeon or the oncosurgeon. So what is the endocrine association of carcinoid syndrome? That is what I shall be talking about. We have the chairperson who is clearly, who will know a lot about this also, but my focus is on the endocrinological aspect of carcinoid syndrome. First up, the difference between what carcinoid tumor is and what carcinoid syndrome is. So carcinoid tumors are neuroendocrine neoplasms, NENs, which I shall refer to subsequently, usually originate in hormone producing cells that line the small intestine or other parts of the digestive tract. Also in the pancreas, in the lungs, where the usual term is bronchial carcinoid, rarely in the testes or the ovaries. So basically, embryologically, gut, foregut, midgut, and hindgut associated tumors. Now, what is carcinoid syndrome? This is a diverse set of symptoms simply because of excess hormones that are produced by these carcinoid tumors, wherever the location may be. The association is there of the syndrome is there with some tumors more than other locations, and I shall talk about them. So basically, that is the difference between what the tumor is and what the syndrome is. Now, the epidemiology, so carcinoid syndrome occurs mainly in gastrointestinal or lung-related neuroendocrine neoplasms. The incidence of the carcinoid syndrome is around 1 in 100,000 population, depending on whichever data you choose to follow. So this is from the Lancet Oncology. Carcinoid syndrome has a prevalence of around about 20% in all cases of neuroendocrine neoplasm. And if you look at the prevalence based on the site, so small intestinal carcinoids are around 42% of the total, followed by rectal carcinoids. Then you have bronchopulmonary carcinoids, 25%, and stomach carcinoids are around 9%. Now, what is the syndrome a function of? What is the carcinoid syndrome dependent upon? This is what I'm speaking about. So the occurrence of the syndrome will be dependent upon the tumor mass of the carcinoid. Secondly, the extent and the localization of the metastases that have occurred. And finally, the localization of the primary tumor itself. So these are the three things on which the occurrence, the happening, the carcinoid syndrome occurring will be dependent upon. And the syndrome will be most common in tumors that originate in the small intestine and the proximal colon. So up to 60% of patients with tumors in the small intestine and proximal colon will experience the syndrome. On the other hand, bronchial and midgut carcinoids produce the carcinoid syndrome much less frequently, while in the case of rectal carcinoid, the syndrome is more or less unheard of. Finally, the point of syndromic patients mostly having liver metastasis. So the liver is able to inactivate the amines and the peptides that are produced from tumors if it comes to the liver via the portal circulation. However, in cases of liver metastases, it is really these peptides and amines reaching the systemic circulation without bypassing the portal circulation. And that is why you've got syndrome, the carcinoid syndrome occurring in patients mostly who have liver metastases. So clinically, you have diarrhea occurring in around 80% of cases. It is usually a secretory diarrhea with associated fluid and electrolyte imbalances possible, and occurs because of increased gastrointestinal motility, which is caused by the hormones of the tumor, which may be mainly serotonin, tachykinins, histamines, kallikrein, and prostaglandins. What these do is that they stimulate peristalsis of the intestine, they increase electromechanical activity, and they stimulate intestinal tone. The second feature which we understand of the carcinoid syndrome is flushing. So in some cases you may have more of flushing, some cases you may have more of diarrhea, but more or less about the same prevalence rate, around 70 to 80%. Now there are 4 described types of flushing that occur in the 70% cases who will have that of the carcinoid syndrome. One, as the name itself suggests, the first one is erythematous flushing, which occurs in cases of early onset midgut carcinoids. Secondly, you have a more violaceous appearing, a more violet, darker appearing flush, which occurs in midgut carcinoids in the later stages of the midgut carcinoid. Thirdly, you have what is known as prolonged flushing, which may last up to several days. Usually the flushing lasts a few hours at the most, but in the case of prolonged flush, it may last for several days. And this is ominous because prolonged flush may be a harbinger of, maybe an indicator of a malignant bronchial carcinoid. And finally, you have, as the name suggests, a bright red flush, which characteristically occurs in gastric carcinoids, characteristically ECLomas, enterochromaffin-like cellomas. Now, the usual areas for appearance of the flush are in the upper part of the body, so face, neck, and upper chest characteristically. What precipitates flushing? One, it is stress. Secondly, if you stimulate the vagus nerve by brushing teeth or by chewing, then that can be a precipitating factor for flushing in carcinoid syndrome. And thirdly, foods that contain tyramine and alcohol. So what are the tyramine containing foods? Mainly cheese, coffee, chocolate, nuts like walnuts, avocados, bananas, and red wine. Now, if you have a patient of presenting with flushing, there is a whole host of possible differential diagnoses. Not all of these will be having carcinoid syndrome. These are some of the important ones. So you may have a fever, a benign cutaneous flush, rosacea. Climacteric is a frequent occurrence in patients who are perimenopausal. And that, of course, for that, you'll have to look at the patient age group and the presence of elevated FSH, if any. Carcinoid, as I mentioned, is one cause associated with hypotension and the other features such as diarrhea and bronchoconstriction. Pheochromocytoma, characteristically, the flush that comes with it will have hypertension. In the case of mastocytosis, systemic mastocytosis, which is an important differential diagnosis, there will be abdominal symptoms predominant, along with weight loss and hypotension again. Anaphylaxis, of course, we know how to distinguish that. Medullary carcinoma thyroid can be associated with a flush. You have to look for the other features of associated with MCT, such as PO and hyperparathyroidism. Then you may have a pancreatic cell tumor in the form of vasoactive intestinal peptidoma. Where, of course, you will have a prolonged watery diarrhea. And finally, rarely, a renal cell carcinoma can also present with a flush. Other features of carcinoid syndrome are abdominal pain, so that may occur in up to 40% of cases, related to mesenteric fibrosis, which occurs as a result of the hormone secreted from the carcinoid. Then wheezing and bronchospasm is another feature, but only occurs in up to 20%, related to obviously the hormone excess. Palpitations can occur up to 30 minutes, and there may be itching or skin rashes, which are related to the excess of histamine secreted from the tumor. There is a feature called carcinoid heart disease, which may occur in up to 77% of carcinoid syndrome cases. What is carcinoid heart disease? It's a plaque-like thickening of the endocardium, the leaflets of the valves, the atria, and the ventricles. Occurs in up to 10 to 20% of the patient. There are both stenotic and regurgitant lesions possible. And what is pathognomonic of carcinoid heart disease is the presence of new collagen beneath the endothelium of the endocardium. Characteristically, carcinoid heart disease presents with right-sided fibrosis in patients who have liver metastasis, who usually also have the carcinoid syndrome. Now, there is a correlation between the circulating serotonin and tachykinins and the severity of the carcinoid heart lesion. And the marker for carcinoid heart disease is NT-proBNP. This is a prognostic as well as a diagnostic marker. It is the best marker for carcinoid heart disease. As I mentioned, up to 77% of patients with carcinoid syndrome may have the carcinoid heart disease. Carcinoid crisis is another term. Very simple, I'll just simplify it and shorten it. Carcinoid crisis is very similar to what we understand as being the thyroid storm. So in terms of pathophysiology, this is what is happening in carcinoid crisis as well, similar to a thyroid storm. It may occur spontaneously, it may occur during induction of anesthesia or embolization or chemotherapy or infection, characterized by an exaggeration of the normal symptoms. So you may have severe flushing, diarrhea, hypotension, hyperthermia, and tachycardia. And if the crisis occurred during or prior to surgery, then you may need to give octreotide, intravenous or subcutaneous, pre, intra, and post-operatively for a varying degree of time. You have other interesting endocrine rarer manifestations of carcinoid. So you may have Cushing syndrome related to ectopic ACTH or corticotropin releasing hormone, which usually arise from pulmonary and thymic carcinoids. You may have acromegaly, rarely because of ectopic growth hormone releasing hormone from foregut carcinoids. Gastric carcinoids are classified as type 1, type 2, type 3. Type 1 carcinoids give rise to chronic atrophic gastritis. Type 2 gastric carcinoid, which we understand as very well from our medicine lectures. This is what gives rise to the Zollinger-Ellison syndrome, where you have severe hypergastrinemia and severe acid peptic disease. So this is type 2 gastric carcinoid. And type 3 gastric carcinoids are sporadic, more malignant, and there is no hypergastrinemia in these. Now, a brief word on the biosynthesis of how serotonin goes about. So, it is the amino acid tryptophan which is at the heart of it, of serotonin metabolism. It is acted upon by tryptophan hydroxylase to give rise to 5-hydroxytryptamine, which is decarboxylated to 5-hydroxytryptamine. 5-HT is what is the chemical name of serotonin. This is acted upon by monoamine oxidase to give rise to 5-hydroxy-indole acetic acid, indole acetaldehyde, and an aldehyde dehydrogenase enzyme then acts upon this intermediate to form what we know as 5-hydroxy-indole acetic acid, 5-HIAA, which, as we know, plays a crucial role in the biochemical determination of the syndrome. So 5-HIAA this is how it comes formed from serotonin. Now, this is a classification. This is, of course, of more interest to the esteemed chairpersons today, but I shall briefly mention it. This is the WHO classification of gastroenteropancreatic neuroendocrine neoplasms. They may be widely well differentiated or poorly differentiated. If they are poorly differentiated, they come classified as carcinomas. And this is dependent. This classification from G1 to 3, well differentiated, is dependent upon Ki67 index and the mitotic index. And if it is poorly differentiated, then the Ki67 index stands at more than 20% and the mitotic index at more than also more than 20%. The WHO classification for lung neuroendocrine neoplasms is, of course, again dependent upon Ki67 index and mitotic index and the presence of necrosis, if any. And they are therefore classified as being low, intermediate, or high grade. Now, this is the classification of carcinoid tumors, which we have traditionally understood. That they may be foregut carcinoids. So embryologically, they may have come from the foregut or midgut or the hindgut. Histopathologically, these are the characteristics. Importantly, molecular genetics, there is an association with foregut and midgut carcinoids with regard to the following deletions, as mentioned. But in the case of hindgut carcinoids, there is no associated molecular pathology known. There are a number of secretory products, hormones from foregut carcinoids, midgut, and hindgut. If you see in the hindgut carcinoids, the number of hormones elucidated are very small, and one of them is somatostatin. And this is indeed one of the reasons why you don't have any carcinoid syndrome with hindgut carcinoids. On the other hand, foregut, midgut, as you can see, give rise to a number of these vasoactive substances which can produce symptoms. So carcinoid syndrome will be present in around 30% of foregut carcinoids. And let's remember, bronchial carcinoids are part of foregut carcinoids. So it will be present, carcinoid syndrome, in 30% of foregut carcinoids. Midgut carcinoids are the ones which give rise to the maximum cases of carcinoid syndrome. So up to 70% of carcinoid syndromes will happen in cases of midgut carcinoids, while hindgut carcinoids, you don't get carcinoid syndrome for the reasons that I mentioned. How do you diagnose the syndrome? The biochemical diagnosis rests upon 24-hour urinary 5-hydroxy-indole acetic acid, which I mentioned in the biosynthesis of serotonin. This is less sensitive, so sensitivity comes to around 80%, but it is very specific for the syndrome. Serum chromogranin A is the second biochemical marker, which is more sensitive but less specific than urinary 5-HIAA. And platelet serotonin levels are often useful, can often be more specific also than the above two, and they can add on to the diagnosis if you are not fully convinced. So you can use all three of them, 5-HIAA, urinary, serum chromogranin A, as well as platelet serotonin, to increase your predictability, to the predictive power of your diagnosis. Plasma neuron-specific enolase is less sensitive and specific than chromogranin A. But importantly, it is useful in lung neuroendocrine tumors, and those tumors which have a higher proliferation rate. Now, there are substances which can interfere with the 5-HIAA assay. This we have to remember. There can be false positive 5-HIAA because of these theremin containing fruits that I talked about when I talked about the precipitating factors for flush. And drugs like salicylates, so aspirin, caffeine, and paracetamol may also cause a false positive in the HIA assay. The other drugs are, of course, less commonly used. False negatives may occur with the use of heparin, chlorpromazine, imipramine, etc. How do you localize a tumor? So you've biochemically established it is a carcinoid syndrome. How do you localize now where the tumor lies? Now, previously, the preferred initial modality was a whole body somatostatin receptor scintigraphy, or what we know as octreoscan with indium DTPA, phenylalanine octreotide. So this is what we know as what we call octreoscan, but we know that an octreoscan may take up to 24 to 48 hours for to get the final result. And therefore, recently, gallium-68 dotatate or TOC PET scan has been shown to have a higher sensitivity than octreoscan, and therefore, in places where you have this modality available, it has actually become the preferred imaging modality compared to octreoscan. You may use CT or MRI for diagnosis of liver metastases, and F-DOPA PET scan using C5-HTP is useful to monitor therapy results, but not so much to make the initial diagnosis, because we know that F-DOPA PET shows up areas which are actively metabolizing. So that is the more malignant part, the more actively proliferating part. And therefore, if you want to show an improvement or deterioration following therapy, then the F-DOPA PET will be able to show you an increased color in that particular area if it is more actively proliferating than before. So more important to use, more useful to monitor therapy results, but not so much to diagnose. How do you treat? Tumor reduction and symptomatic control are the keystones. Long-acting somatostatin analogs are the cornerstones of therapy. What they do is that they bind to the somatostatin receptor 1 and 5 receptors, less so to the SSTR3 receptor, and as a result, they reduce the growth factor production from the tumor and have an anti-proliferative effect as well. So you have improved biochemical control, improved symptomatic control, in lesser size of the tumor as well. And the agents are octreotide and the long-acting monthly preparations of the octreotide LAR and lanreotide. So demonstration in tumor size has been demonstrated with reduction in tumor size has been shown with the use of high dose of these long-acting somatostatin analogs. The problem with this is the development of tachyphylaxis. Then, of course, you may also have GI side effects and the development of gallstones. In the case of the second treatment modality is the use of interferon alpha 2A and alpha 2B, which brings about biochemical control as well as reduction in the size of the tumor. You can combine it with somatostatin analogs, which gives better results because we know that, as I mentioned, the somatostatin analogs bring about tachyphylaxis quite quickly. And therefore, if you combine both these two treatment modalities, you expect better results. The problem, the side effects are, of course, chronic fatigue syndrome, the cytopenia development, and the development of autoimmunity. Chemotherapy is a modality that is attempted mainly in foregut carcinoids, which are more malignant. So you may have these following regimes have been tried: ceftazocin plus 5-FU, doxorubicin, cisplatin plus etoposide, dacarbazine and 5-FU, and the newer agent temozolomide. Finally, surgery. So you may consider debulking procedures even if the tumor is has spread widely. It will improve the response to therapy. You can consider resecting the local disease if you are able to do so. And finally, hepatic artery embolization produces quite a good response in terms of symptom control. What about the role of irradiation? External beam irradiation is only palliative for brain as well as bone mets. But now you have the development of, just like in the diagnosis, the localization of the disease. Similarly, somatostatin analog-based tumor-targeted radioactive therapy has been developed using I-125 or I-131 or indium DTPA octreotide or yttrium dotaoctreotide or lutetium dotaoctreotide. So these are somatostatin analogs, and these target the tumor based on the avidity of the somatostatin receptors. To sum up, this is a proposed algorithm for management. You have clinical history and imaging findings suggestive of mass. Next, you move on to staging CT scan for chest, abdomen, pelvis, a nuclear medicine scan with gallium DOTA PET imaging, or an octo scan if whichever is more convenient. A lesional biopsy should be considered, and biochemically you look for 5 urinary HIA, chromogranin A, along with baseline investigation. You confirm the diagnosis, refer to a neuroendocrine specialist team. If there is the presence of carcinoid tumor in the small bowel, you commence somatostatin analog. If the disease is localized or metastatic, which is resectable, then you must consider surgery to be able to give a better chance at survival. If the disease, however, continues to progress, then you must consider what I talked about, the lutetium-77 dotatate therapy, which is SSTR analog-based radioactive therapy. Locoregional therapy can be used in the form of hepatic embolization or radiofrequency embolization. Now, if the disease is non-resectable, you continue somatostatin analog. If it is non-progressive, but the syndrome, carcinoid syndrome is refractory, then you optimize somatostatin analog. You consider locoregional therapy. Tilotristat is a newer agent, which is an inhibitor of tryptophan hydroxylase. So by using that, you reduce serotonin production, you improve symptoms. And of course, you can consider for debulking. If the disease is non-resectable and continues to progress, then the algorithm moves on to the left part, the bottom part, which I already talked about. With that, I come to the end of what I had to say. Thank you very much.